Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will present an original article published in the January issue of IJA. It is on the safety and efficacy of remifentanil in patients undergoing bariatric and metabolic surgeries, a systematic review. Obese subjects have high propensity to experience opioid-induced respiratory depression and airway obstruction in the postoperative period. The prevalence of central sleep apnea, hypoxia, and OSA increases with obesity, and patients with redundant pharyngeal tissue are susceptible to upper airway obstruction. After the opioids are administered, there is increased risk of upper airway obstruction, OSA, and hypoxia. Now, remifentanil is metabolized through non-specific tissue and plasma esterases, leading to organ-independent clearance of the drug. Even with the prolonged administration of this drug, its quick elimination of effect is explained by its fast metabolism. It is given as a continuous IV infusion for sedation or in combination with IV hypnotics or inhalational agents. Most studies have demonstrated a favorable profile of remifentanil in patients undergoing bariatric and metabolic surgery. To date, no qualitative systematic review or quantitative meta-analysis has investigated the efficacy of remifentanil in terms of better pain scores, longer times to rescue analgesia, and safety in terms of fewer adverse events like respiratory depression and nausea vomiting in patients undergoing bariatric and metabolic surgeries. The trial is registered with Prospero. It is a systematic review. Only RCTs were included in the review, and no non-English studies, research involving animals, studies without available full text, systematic reviews, literature reviews, scoping reviews, case report series editorials, and conference or abstracts were excluded. Relevant keyword searches for RCTs was done from January 2000 to May 2024 using the terms remifentanil, anesthesia, bariatric surgery, and metabolic surgery in PubMed, Cumulative Index to Nursing and Allied Health, OVID, and Cochrane Central Register of Controlled Trial Databases, and also clinicaltrials.gov. The primary outcome was to compare the safety and efficacy of intraoperative remifentanil with those of other opioids or opioid-sparing medications in adult patients undergoing bariatric metabolic surgeries by assessing pain scores in the postoperative period. The secondary outcomes were time to rescue analgesia, recovery time, time spent in operating room after surgery, sedation scores in the recovery room, adverse events like respiratory depression in the recovery room, nausea vomiting from recovery room admission up to 24 hours, and the length of hospital stay. The population included were adult patients undergoing elective bariatric and metabolic surgeries under GA. The intervention was the use of intraoperative infusions of remifentanil. The control group, there was use of any other opioid or non-opioid analgesic. The outcomes was safety and efficacy of remifentanil when compared to the control group, and RCTs were included. Meta-analysis was performed using Review Manager software by Cochrane collaboration. To evaluate publication bias, funnel plots of effect size against standard errors for outcomes were analyzed for asymmetry. Risk of bias 2 tool was used, and the overall methodological quality of evidence across the pooled outcomes was assessed using the GRADE guidelines. A total of 7 studies were included in this systematic review. The bias for randomization process was high in 2 studies. Bias due to deviation from intended intervention, that is allocation concealment, was high in one of the study. Bias arising from missing outcome data was low in 4 studies, high in 1 study, and there was no information in 2 studies. Bias in outcome measurement was low in 4 studies, high in 1 study, and there needed to be more information in 2 studies. Bias arising from selection of reported results was low in 6 studies and high in 1 of the study. This is the table showing the outcome data of all the included studies, which included the total number of patients, age, gender, weight, BMI, pain scores, PONV, 24 hours opioid consumption, surgery duration, and anesthesia duration for all the studies. Significant heterogeneity was seen in the control group, with opioids used as control in 2 studies and non opioids used in the remaining 5 studies. In such a situation, conducting a meta analysis of effect estimates is either impossible or inappropriate. The high risk of bias seen in the included studies may significantly impact the validity and reliability of the findings. The quality of evidence using the grade was low for PONV and very low for pain scores in recovery room and 24 hours opioid consumption. The analysis done revealed that the incidence of nausea vomiting was higher in remifentanil group compared to the control group, and that other outcomes like pain scores and 24 hours opioid consumption were comparable between the two groups. Remifentanil was compared to various opioids and non-opioid drugs such as lobetalol or dexmed in different dosages in the included studies. Since different doses produces varying analgesic scores, it was impossible to make any meaningful comparisons. Therefore, the systematic review investigated the safety and efficacy of use of remifentanil in adult patients undergoing bariatric and metabolic surgeries when compared to the control, which comprised other opioids like fentanyl, sufentanil, or opioid-sparing agents like dexmed or labetalol as a part of multimodal analgesia. A pooled analysis was not performed due to inconsistency in the control group. The strength of this systematic review is that only RCTs were included. The limitation of this review is the inability to report the quantitative meta-analysis due to underlying clinical heterogeneity in the included studies, especially the medications used in the control group. Opioids are routinely used in patients undergoing bariatric surgeries, not only perioperatively but also after discharge from the hospital. And fentanyl is the most commonly used opioid for these surgeries. Irrespective of the type of opioid, the patients are susceptible to perioperative respiratory adverse events. Therefore, it is suggested to have a tailored approach for managing perioperative analgesia in these patients by using multimodal medications based on the patient's risk factors. Additionally, adding regional anesthesia techniques can have significant opioid sparing benefits, providing better quality analgesia and reduce the events of nausea, vomiting, constipation, and other adverse events. The regional techniques which can be used are thoracic epidural, bilateral tab block, bilateral erector spinae blocks, and quadratus lumborum blocks. Intraperitoneal instillation of local anesthetic has also been used for reducing the postoperative pain, but the results are equivocal. Many non-opioid adjuvants have been used with reasonable success as a part of multimodal opioid-sparing analgesia in patients undergoing bariatric surgeries. The limitations of the present systematic review is that the control group was inconsistent. It was either other opioids or non-opioid medications like dexmed or labetalol. Outcome reporting was also inconsistent. All RCTs did not report the primary outcome, that is, the pain scores measured in the recovery room. Other outcomes like time to first rescue analgesia, respiratory depression were not compared in all the studies, and hence they could not be analyzed in all the RCTs. Clinical and statistical heterogeneity, which could be a hurdle in accepting the findings of this review. Therefore, the results of this review should be interpreted with caution. The authors suggest studies in the future that are adequately powered and meticulously designed to elucidate the efficacy and safety of remifentanil in patients undergoing bariatric surgeries. To conclude, the current evidence does not support or deny the routine use of remifentanil for patients undergoing bariatric surgeries. This is owing to the significant heterogeneity in the control group, which was not consistently opioid based. Further studies are necessary to explore its efficacy and safety over other opioids and non opioid medications. Thank you.